Pneumocystis IROVECII is a host-specific opportunistic fungal pathogen. It was previously classified as a protozoan but is now categorized as a fungus. The infection primarily targets immunocompromised hosts. These include individuals with HIV, J transplant recipients, and those with hematologic malignancies. Patients on high-dose glucocorticoids or immunosuppressive monoclonal antibodies are also at high risk. Transmission occurs via the respiratory route, with humans as the only reservoir. Most cases in HIV patients occur when CD4 counts fall below 200 cells per microliter. Susceptibility is highest when the count is less than 100 cells per microliter. The organism proliferates within the alveoli, causing proteinaceous foamy alveolar exudates. This process leads to alveolar capillary damage and surfactant dysfunction. Lung histology reveals foamy vacuolated alveolar filling. There is typically a concurrent mononuclear interstitial infiltrate observed in tissue samples. The clinical presentation is typically a subacute pneumonia. Patients present with fever, a non-productive cough, and progressive dyspnea. In patients without HIV, the disease often follows an acute course. Rapid progression to respiratory failure can occur within just a few days. Physical examination is frequently normal in the early stages of the disease. Later findings often include diffuse RALs and progressive hypoxemia. Elevated LDH levels are a common but nonspecific laboratory finding. Importantly, a normal LDH level does not definitively exclude PCP. Chest X-rays classically demonstrate bilateral symmetric perihilar interstitial infiltrates. However, the imaging may appear normal during the early phase of infection. High-resolution CT scans typically show diffuse ground glass opacities. A normal CT scan essentially rules out a diagnosis of PCP. Bronchoalveolar lavage with organism identification is the gold standard for diagnosis. It provides sensitivity and specificity approaching 100%. Identification is achieved using methenamine silver, GIMSA, or toluidine blue stains. Immunofluorescent antibody testing is also highly effective for detection. PCR testing is highly sensitive but cannot reliably distinguish colonization from active disease. It is most useful when the result is negative to rule out infection. Serum 1,3 beta-D-glucan is often elevated in these patients. While sensitive, this marker is not specific to Pneumocystis infections. First-line therapy is TMP to SMX for 14 to 21 days. The dosage is TMP 5 mg per kilogram plus SMX 25 mg per kilogram every 6 to 8 hours. Adverse effects include rash, fever, cytopenias, and hepatitis. Electrolyte imbalances such as hyperkalemia are also common during treatment. Adjunctive corticosteroids provide a major survival benefit in moderate to severe cases. Start steroids if PaO2 is less than 70 millimeters of mercury. Steroids are also indicated if the A2 gradient is 35 millimeters of mercury or higher. They should be initiated at the start of antimicrobial therapy. The recommended regimen is prednisone 40 mg twice daily for 5 days, then reduced to 40 mg once daily for 5 days, followed by 20 mg daily. Patients may clinically deteriorate during the first 3 to 4 days of therapy. This is often an inflammatory response to the dying organisms. If first-line therapy fails, consider switching to intravenous pentamidine or clindamycin plus primaquine. Pentamidine must be infused over 60 minutes to prevent hypotension. Prophylaxis is indicated for HIV patients with CD4, counts under 200 cells per microliter. It is also advised for those on 20 mg of prednisone for 30 days. TMP to SMX at 1 double-strength tablet daily is the most effective prophylactic regimen. For patients with sulfa allergies, dapsone or ativaquone are acceptable alternatives. Untreated PCP is invariably fatal, so early recognition is paramount. Use adjunctive steroids early in severe cases to significantly reduce mortality.